not only are checkpoint inhibitors being evaluated in metastatic bladder cancer, but a whole variety of different targets are being evaluated as well at this particular point. So HER2 new targeted therapy, that's actually been around for a long time. There have been some early studies combining Herceptin with chemotherapy. Arjun, were there any studies at this meeting, or have you been aware of any other studies that have looked at HER2 new therapy?
So you've obviously referenced a prior study of gemcitabine carboplatin with Herceptin. More recently, people are looking at Herceptin with pertuzumab. There was one poster that I saw here at GU ASCO looking at Herceptin and pertuzumab in a very relatively small study. There were actually some durable responses. In fact, I actually spoke to one of the lead investigators. Therapy was well tolerated. There was one CR that actually was quite durable. And combining HER2-directed therapies it makes some sense in this disease. Actually, we look back at the TCGA. What was unique is that we did see some HER2 amplification in the TCGA, but there was also HER2 mutations, which we actually don't really see too often in other solid tumor malignancies.
Yeah. The interesting thing about Maha Hussein's study, when you look at the characteristics of those patients who were on the trial, and there were a variety of different ways of measuring HER2 expression, but most of them had poor prognostic features. Yeah. And perhaps this may be a marker of more advanced disease. So there have also been some TKI trials. Tom Powell's has actually looked at giving a HER2 TKI as adjuvant therapy post-treatment. Really didn't see much of a difference in overall progression-free survival. But I think the data that was presented with the checkpoints here in combination with Herceptin was very, very intriguing. So Betsy,
but you can't draw, one of the issues is the biology of HER2. There's overexpression, there's amplification, there's mutation. And so, for example, in Maha's study, it was overexpression, and they used the breast data. The DACO study agrees with ERB2 mutations.
And the challenge is
that's not the case.
And mutations may not be sensitive to monoclonal antibodies. In fact, HER2 mutations may require a small molecule inhibitor to target the intracellular domain.
Right, and those studies are ongoing.
Actually, Maha's study was one of 4 different methods. If you hit positive on any one, you could be entered on the trial. So I think it was more of actually a trial to define toxicity rather than actual efficacy. But interesting nonetheless. So I mean, certainly this is a target that we want to move forward with. Angiogenesis is also an important target. We're still awaiting Jonathan Rosenberg's trial from CALGB looking at bevacizumab plus gemcitabine in cisplatin versus cisplatin alone. And I think that all of us are anticipating that final result. But there are other anti-angiogenesis agents that are now being evaluated. Betsy, do you want to talk about ramucirumab and docetaxel?
Sure. So ramucirumab actually presented phase 2 data, I think a couple of years ago, and based on preliminary encouraging results from those data, launched a phase 3 trial, which is underway. So I think we'll have a real answer on that, and I think, none of the drugs in that trial are immunotherapeutic per se, so I think we'll need to then figure out where it fits based on what the data shows. So I think it's too early really to comment, except that we look forward to seeing it.
Do we know that VEGF inhibition is not immunotherapeutic?
Per se.
Per se. She said per se. She said per se.
I mean, the mechanism of action defined, you bring up a great point, right? It may absolutely have immunotherapeutic indications, but I think that's how, once we have hopefully a positive trial, right? We hope all our trials are positive. Once we have that, where are we going to put it? Is it better first and then immunotherapy? Is it better second?
Yeah, it's
it is, but I think we can start to think about what we might do.
And certainly, I'd like to make a couple of points about, angiogenesis in bladder cancer is nothing new, right? Yeah. So we have old data that shows that higher VEGF expression levels in the blood and the urine of these patients, patients do worse. So we know that this is a poor prognostic factor. And older studies, in fact, the study that I was very lucky to participate in when I was a fellow with you, Dean, was the gemcitabine carboplatin and bevacizumab study, and similarly the gemcitabine cisplatin bevacizumab study that Noah Hahn led. And both of those trials demonstrated encouraging PFS and survival compared to what we would consider the historical standard. And what was interesting in our GEM-Carbo-Bev study, in fact, was that the patients who actually continued on maintenance bevacizumab actually had some further tumor regression with single-agent bevacizumab in that particular study. So there are some compelling evidence, and now actually we're looking at bevacizumab as an immunotherapeutic agent is actually really something that's relatively new over the last several years. We're looking at that in a phase 2 trial of atezolizumab with or without bevacizumab in the frontline setting in cisplatin-ineligible patients with metastatic disease. I think that study is well poised to answer the question, can bevacizumab truly be immunotherapeutic? beyond just being an anti-angiogenic
Right.
agent.
And pre and post-treatment biopsies,
Right.
paired biopsies in patients getting bevacizumab, you see upregulation of T cells, infiltration, et cetera, in a tumor. So, and this is, this has been true for many years. We think we know how a drug works, and then we get more information. It may work a little differently. Gemcitabine, for example, works against MDSCs, something we've recently learned. So many of these drugs actually may have immunotherapeutic actions in addition to cytotoxicity.
So we all have a feeling that VEGF targeted therapy should work in urothelial cancer. We've just had difficulty proving it. I think if you look at the TKIs for VEGF receptor 2, like pazopanib, for example, sunitinib, you guys did trials, you get a very variable response. You can have one phase 2 set that says, you get a durable response with pazopanib, and then the other, another phase 2 set says there's nothing. So I think the variability in the biology is a bit of a challenge, and it may be that these agents are good partners with checkpoint inhibitors, and whether it's a monoclonal antibody like ramucirumab, whether it's BEV, or whether it's some of the TKIs that we've used more in renal cell cancer, I think it's interesting. So we may not have had the partnership right, and exploring the biology may lead us down the right path. Hopefully we end up with a different set of therapeutics.
So finally, amongst the new agents, the ADCs, Dean, what about the targeting nectin as a potential target for bladder cancer?
Yeah, there's early data that might be, in fact, active. I think what it does is it points out an issue that I think all of us are facing, and that is new drug development in patients who may not respond to immunotherapy. That's the vast majority of patients. This also, at least in early data, looks like there is activity there. So we'll need more follow-up with regard to that drug, but there is some early activity that is certainly worthwhile.
It certainly looks interesting. And the other area that I think that we're also moving into are therapeutic vaccines. You mentioned before the HER2 new dendritic cell vaccine that was the new Venge, but PanVac, also New York ESO. Any of the panel members have experience with any of those other vaccines in this disease?
So I have with New York ESO 1 because it was developed at the Ludwig when we were there. We've actually had several vaccines that we've attempted over the years with regard to the New York ESO 1 vaccine. It's part of the cancer testis antigens, MAGE, phage, et cetera, and New York ESO 1 is a member of that group. I think so the first issue is, yes, they're actually immunogenic. We've actually years ago identified a patient who expressed New York ESO 1 who had a high T cell recognition of that particular antigen. So I think we will start seeing studies that expose antigens or neoantigens or induce neoantigens, that we can then allow recognition in terms of IO checkpoint blockade. But these are all in their infancy, really.